if people are coming or not, but welcome and thank you for coming to the tutorial about aspiration pneumonia. My name is Michael Niederman and I'll be discussing the topic, and hopefully we'll have time for a little discussion towards the end, but a lot of material that I'd like to try to cover. I've listed my conflicts on this slide, and we're going to be talking about aspiration pneumonia, and a lot of this will be based on a review article that we just published last month in the New England Journal, reviewing a variety of the aspects of aspiration pneumonia. And so if you'd like to read more, much of the material I'll be discussing today is taken from this review. So I guess I'll start with maybe the most obvious question, and that is, isn't all pneumonia aspiration? Is there really such a thing as aspiration pneumonia? And I think technically the pathogenesis of all pneumonia involves aspiration from a colonized oropharynx, but when we use the term aspiration pneumonia, what I mean to refer to is macroaspiration from a colonized oropharynx or GI tract. So this would not be the small amounts of secretions that get into the lower respiratory tract in all of us when we sleep and throughout the day, but this is macroaspiration, large volume aspiration, and a number of factors determine whether patients who aspirate become ill. Those factors include the bacterial virulence, which includes also the inoculum size, the risk of recurrence, which is a patient factor, and the site of acquisition determines the bacteriology. To some extent, did the aspiration event occur at home, in the hospital, and so forth. Aspiration can involve the airways or the parenchyma, and what I'd like to talk about today is involvement of aspiration in the parenchyma, not the airways. There are characteristic anatomic locations that give us clues to the pathogenesis being macroaspiration, and the pneumonitis that results from aspiration can be a bacterial infection or a chemical pneumonitis. There are a variety of aspiration syndromes. Again, acid chemical pneumonitis. There can be aspiration of a foreign body, aspiration of bacteria, and to really make this diagnosis, you generally need a patient clinical risk factor, such as altered consciousness, difficulty swallowing, protracted vomiting, some mechanical disruption of the defense barriers, and the characteristic locations are dependent on the lung anatomy. The right side much more often affected than the left side, and the lower lobes and the posterior upper lobes affected primarily by gravity if the patient is supine when the aspiration event occurs. Generally, patients with poor dentition are more prone to developing aspiration infection. And one of the rare diagnoses to think about, particularly if you have chest wall involvement, is actinomycosis, which also occurs in aspiration and is a distinctive syndrome. So again, remember the anatomy. The right and the left main stem bronchus are not identical. The right main stem bronchus is wider. It's more vertically aligned than the left main bronchus, and material is preferentially going to go to the right side. So aspiration is more common on the right side. And we know, of course, from clinical practice that when we're intubating patients, it's easy to intubate the right main stem bronchus because of this same anatomy. And that's illustrated here. As you can see, the right main stem comes off much more vertically from the trachea, whereas the left main stem comes off at more of an angle. So aspiration into the right side is more common than aspiration into the left side. The microbiology of aspiration is changing. We used to think of aspiration pneumonia as primarily an anaerobic infection. That's probably less so today. Anaerobes, as I'll show you, are much less common, and much more commonly now we see more classical HAP and VAP, as well as community-acquired pneumonia pathogens. There's some discussion that was included in our review article about the role of the microbiome, which is a very important concept in infection pathogenesis, the thinking being that chronic illnesses of all type change the microbiome, and the change that's most important in the parlance of microbiome is a loss of bacterial diversity. Diversity is a good thing, and as patients become chronically ill, they lose diversity. That change in the microbiome is associated with altered immune function and impaired host defenses. And if a patient with chronic illness and impaired immune function has a macroaspiration event that overwhelms those altered immune function and prevents bacterial elimination, that causes more inflammation and establishment of infection in the lower respiratory tract, And so a preceding alteration in the microbiome is probably part of the pathogenesis of aspiration. Again, we've learned over the last several years that anaerobes just are not as important in aspiration as we've thought. This was one of the earlier studies done in 140 patients with over 180 VAP episodes. There were 25 patients in this cohort who clearly had aspiration and required mechanical ventilation. They had quantitative cultures done, and only 12 of the 25 patients who aspirated was there actually an aspiration pneumonia. And in that group, there was one anaerobic organism, and it was not considered even a true pathogen. So anaerobes are much less common. And I think a more contemporary and I think more impressive study to me is this study done now, still a while ago, but done in 95 patients greater than the age of 65 who came from long-term care facilities, were admitted to the intensive care unit because of what was defined as aspiration pneumonia. They were defined as having aspiration pneumonia based on epidemiologic risk factors, GI disease, swallowing problems, neurologic problems, or anatomic disease. And all of these patients had a protected bronchoalveolar lavage within 4 hours of admission. So very good, deep lower respiratory tract cultures. And if you look at the distribution of pathogens, you can see that in general, there was a predominance of gram-negative bacteria, there was some Staph aureus, and altogether there were anaerobes in 11 patients, but in only 6 of them were there anaerobes, in 6 of them there were aerobic bacteria with anaerobic bacteria. 7 of these patients didn't even get what was considered adequate therapy, and yet 6 of them responded. So it really remains unclear how important anaerobes are, and even if you need to treat them, the fact that patients with anaerobes get better without specific anti-anaerobic therapy, to me is a very important observation because it suggests one of 2 possibilities. Either anaerobes are bystanders and aren't important, or maybe they're partly pathogenic, but by eliminating the coexisting aerobic bacteria, you eliminate the favorable growth conditions for anaerobes and they no longer persist and lead to infection. So I think the real take-home message from this is that if you're thinking of aspiration pneumonia as being an anaerobic disease, and because of that you're consistently using anti-anaerobic therapy, then that's probably not necessary, and that's probably one of the many factors that's contributing to the emergence of VRE in our ICUs, the gratuitous use of anti-anaerobic therapy. So I think it's been very well established that anaerobes are not nearly as important today as they were years ago when aspiration pneumonia was first studied. In terms of pathogenesis, pathogenesis involves an understanding of risk factors, and we divided the risk factors up into impairment in swallowing, impaired consciousness, changes in the ability of organisms and material to reach the GI tract, and then impaired cough reflexes, and a variety of neurologic diseases, GI diseases, upper airway diseases, and a variety of medications all contribute to aspiration risk through those mechanisms of altered swallowing, consciousness, and cough reflex. And there are drugs that are now being proposed, for example, as prevention of aspiration that work via the cough reflex. One of the very interesting observations that I've come across recently is we know that because of impaired consciousness and swallowing difficulties, patients with stroke are more prone to developing aspiration. Many patients who have had stroke have hypertension that needs to be treated. There's a very interesting set of studies that have looked at ACE inhibitors and shown that ACE inhibitors in stroke patients to control hypertension actually prevent aspiration pneumonia because of they causing increased cough. Ordinarily, we don't use ACE inhibitors very widely because many patients who get them do cough, but in stroke patients with aspiration risks, there have been intervention studies with ACE inhibitors that show that by enhancing cough reflex, they can actually prevent the development of aspiration pneumonia. If we look at the risk factors for nursing home pneumonia, again, many of these are aspiration risk factors: impaired swallowing, inability to properly eat, inadequate oral hygiene, and witnessed aspiration is an extremely important risk factor for aspiration pneumonia in nursing home patients. Again, one of the problems with defining aspiration pneumonia as macroaspiration is, although we understand that that's why it happens, a lot of times these aspiration events aren't witnessed either at home or in the hospital, and so they're presumed and not necessarily proven in all patients. Specific risk factors that you need to think about in the ICU population, post-extubation aspiration is extremely common. We need to think about that when we extubate a patient and think about feeding them. At least 20% of patients post-extubation do have dysphagia and aspiration, and although this declines over time, in one study, 35% of the people who had dysphagia and aspiration post-extubation continued to have aspiration at the time of discharge. So I think that this is one of the important complications of endotracheal intubation that we need to remember. The other thing to think about is degenerative neurologic diseases like stroke that can interfere with consciousness, but there are a variety of medications that also interfere with consciousness and with swallowing and protection of the airway. Narcotics are obvious, as well as alcohol, but interestingly, the most important medication statistically leading to aspiration is antipsychotic medications, and enteral feeding also can contribute to aspiration, in part by creating a large volume in the stomach, and if that's combined with some impaired consciousness, that too leads to an increased risk of aspiration. This is a 68-year-old patient in generally good health who had several weeks of cough, bloody sputum, and some weight loss. He had terrible teeth, extensive decay on his lower teeth. He didn't have any other obvious risk factors for aspiration, and yet when we saw his x-ray and we saw this cavitary infiltrate and the multiple infiltrates in areas that were thought to potentially be aspiration sites, and taking his history, he was on an antidepressant medicine that was known to cause somnolence, and we presumed that because of these infiltrates in that clinical setting, that the pathogenesis of his cavitary pneumonia was aspiration. If we look at the outcome of patients with aspiration pneumonia, there's a study from Scotland that looked at 1,400 patients who were, quote, community-acquired pneumonia, but a small group of them, 14%, had aspiration risks. And if you look at the aspiration risk group versus the standard community-acquired pneumonia patients, you see a much lower survival rate. So is it the aspiration pneumonia itself, or is it the patients who aspirate? Probably some combination of the two, but very likely the patients who aspirate have poor outcomes related to the fact that they're an impaired group for a variety of reasons. The other population that I think is very important to remember aspiration in is the post-cardiac arrest patient. And particularly post-cardiac arrest patients who have hypothermia are prone to developing aspiration pneumonia. The French have done some very interesting work on this. This study that's cited here looked at 640 patients with cardiac arrest, and 500 had hypothermia as part of their post-cardiac arrest therapy. Overall, 65% of these post-cardiac arrest patients had early onset pneumonia with hypothermia, and there's some, in the time this study was done, hypothermia therapy was down to 33 degrees, but there's some newer data to suggest that hypothermia to 36 degrees might reduce the risk of aspiration pneumonia. But the putative pathogenesis here is that in anybody who has a cardiac arrest and gets intubated, there are organisms that are colonizing their oropharynx. They may have vomited in the process of their cardiac arrest, and when they get intubated urgently, you can think about the endotracheal tube as a plunger that's taking all of that oropharyngeal secretions and pushing them deep within the lung. And I think that that's a very important part of the pathogenesis of early onset pneumonia in urgently intubated patients, particularly after cardiac arrest. I'm going to talk about that preventively in a few minutes, but also remember that if you treat that population with hypothermia as part of their post-cardiac arrest care, you're further adding to the risk of aspiration pneumonia, and probably additionally should consider some of the prevention strategies I'm going to talk about. What are the clinical features of aspiration pneumonia? Again, a lot of this goes unwitnessed, so the first clue to aspiration pneumonia is the appropriate clinical risk factors. Some patients can be asymptomatic, some can be in respiratory failure, and the presentation can be acute respiratory failure or it can be a subacute process. Along the way, even if they're developing pneumonia, they can develop airway symptoms of bronchospasm, they can have cough, and they can get obstruction of the airway independent of whether they develop pneumonia, and that obstruction can occur with an aspirated foreign body or even with aspirated blood. Patients who have GI bleeding and vomit blood and aspirate that into the lung don't always develop pneumonia or chemical pneumonitis, but the blood itself can lead to an obstructive process in the lung. In the lung parenchyma, again, there can be chemical pneumonitis, there can be bacterial infection, and there can be aspiration of bland material. Again, tube feedings in blood can enter the lung. They can lead to lung infiltrates that are not infection. As I showed you, when there's aspiration present, there's increased mortality. And radiographically, we know these patients more often have bronchopneumonia than lobar pneumonia, and often again in the posterior regions of the lung. This was a very interesting study of elderly people who had foreign body aspiration, and if you look at the localization of foreign body aspiration, not surprisingly, more of it is in the right side than the left side, although still some in the left side. And if you look again, the lower lobe is the most common site. So the right lower lobe was more common for foreign body aspiration than any other site within the lung. And that again fits with our understanding of the role that anatomy plays in the pathogenesis. This is a patient that we saw who had cough after getting dental work with a tooth extraction under local anesthesia. He was a heavy alcohol drinker, and on bronchoscopy had Klebsiella pneumoniae present, but he also had this very characteristically localized posterior infiltrate with cavitation. And so when we took the history, we had his history of alcohol, of recent dental work, and this anatomic location. It seemed very likely that the pathogenesis of Klebsiella pneumonia was an aspiration mechanism. And this is a patient that we saw 80 years old with dyspnea and new, again, gravity-dependent infiltrates, in this case more on the left than the right, that followed immediately after endoscopy, complicated by vomiting. And again, the gravity-dependent location, the history of vomiting, impaired consciousness for the sedation of the endoscopy were all pretty classic for him developing aspiration pneumonia. And so again, it's this combination of risk factors, characteristic radiographic patterns that mostly let us predict that this is aspiration pneumonia. In this case, he was witness to vomit, but in other patients, we didn't know exactly that they had the macroaspiration event. Chemical pneumonitis is also part of the differential diagnosis. In order to develop chemical pneumonitis, you need to macroaspirate a large volume of gastric contents, and the pH needs to be quite low. It needs to be lower than 2.5. It's a very interesting literature when you look at aspiration pneumonia following general anesthesia. I picked this article because I'm not sure I believe it, but it's an interesting statement that in their study, one out of only over 3,000 patients with general anesthesia developed an aspiration pneumonia. They estimated that only about a third of the patients who aspirate and are known to aspirate even go on to develop pneumonia. When chemical pneumonitis occurs, it's sudden onset, it's dyspnea, hypoxemia, diffuse wheezes and crackles. The incidence of ARDS after chemical aspiration is relatively low. It's in one study only 16%, but the risk rises in proportion to other risk factors. So if, for example, the patient has shock and trauma and pancreatitis and aspirates, then that cumulative risk is much higher than 16.5%. And again, bland material that gets aspirated can cause asphyxia, but not necessarily pneumonia or chemical pneumonitis. And in the setting of witnessed aspiration, we don't always give antibiotics. If we're suspecting chemical pneumonitis, we don't want to give antibiotics unless the patients are severely ill. This is taken from the risk factor analysis for ARDS. And again, you can see that the contribution of different risk factors to lead to ARDS is illustrated here, but you can see that aspiration pneumonia only leads to ARDS relatively infrequently, but again, many of these risk factors are cumulative. This was a patient who illustrates the chemical pneumonitis problem. It's an individual with small bowel obstruction. He had repeated episodes of vomiting, and he developed bilateral lung infiltrates in an ARDS pattern. Initially, his cultures were sterile, and then he continued to have infiltrates and eventually was colonized with MRSA, but this patient would be a more typical patient for a chemical pneumonitis leading to ARDS, but not necessarily a bacterial infection. If we look at the radiographic and CT diagnosis of aspiration pneumonia, unfortunately, initial chest x-ray can be negative, and sometimes this can be picked up on CT scanning. Finding in this study was that there was, again, more often bronchopneumonia than lobar pneumonia. If there was a poor performance status, then it was much more common to have diffuse lung infiltrates. And what's illustrated here is, as a proportion of all pneumonias, patients with poor performance status primarily had diffuse infiltrates more commonly than localized infiltrates. And you can see and that the diffuse infiltrates here are the white part of the bar, but poor performance status had predominantly diffuse infiltrates. The other very interesting part of the discussion and the diagnosis here is part of the differential diagnosis is negative pressure pulmonary edema. Now I have to say I'm not sure how often I've actually seen negative pressure pulmonary edema, but in every single patient who we think has aspiration after anesthesia, we're always told by the anesthesiologist, I am 100% sure this patient didn't aspirate during the process of anesthesia, and if they have lung infiltrates, it's because of negative pressure pulmonary edema. The patient I showed you who vomited and developed bilateral infiltrates immediately after endoscopy, we were told by the team that took care of him in the OR that this was negative pressure pulmonary edema. So I think there's a tremendous sensitivity to those who give general anesthesia to think that patients should never aspirate during general anesthesia. And so the most common diagnosis that these patients are given as an alternative is negative pressure pulmonary edema, which is inhalation against a closed glottis, particularly during the extubation process. One of the interesting studies done in the last several years was to ask the question whether procalcitonin could be used to tell the difference between bacterial and chemical aspiration. And this was a very interesting study in 65 patients who were admitted to the ICU with presumed aspiration. Again, quantitative BAL done on day 1 and day 3. And on the basis of BAL positivity, patients were classified as bacterial or chemical pneumonitis. So the presumption was if they were BAL negative, they had chemical pneumonitis. If they were BAL positive, they had bacterial pneumonia. And the procalcitonin levels were looked at in both groups, with the hypothesis being that procalcitonin could tell the difference between them. And unfortunately, as you can see, the levels were virtually identical. So in the editorial that went with this, I was speculating, why did procalcitonin fail? And the problem was that all aspiration patients had a high level of inflammation. You can see that even with the BAL negative, the levels of procalcitonin were higher than in control. And so maybe that inflammation that was set up stimulated the procalcitonin. It predisposed also to secondary bacterial infection. And so unfortunately, procalcitonin was not a good predictor for aspiration pneumonia. How long should we treat and when should we treat? This is another study that looked at patients who were intubated in the ICU with coma. They felt that 98 out of 250 had an aspiration syndrome, and they did empiric therapy directed at anaerobe staph gram-negatives, and they chose by MDR risk. Those that didn't have MDR risk got amoxiclav, those that did got pip/tazobactam, and they saw no differences with bacterial versus non-bacterial aspiration, and they questioned in a letter following the study whether we could be using PCR testing to help with antibiotic decision making in this setting, and I don't think we know the answer to that. And again, if we're looking at the populations, the mortality rate between those with bacterial and non-bacterial aspiration was identical, as was the hospital mortality. In terms of therapy, I won't run through this entire algorithm, but this is taken from our review article. We divide patients up primarily to think about the types of bacteria they may have been exposed to at the time of aspiration. So if they aspirated in the community and they have an abnormal chest radiograph, if they have poor dental hygiene and they have specific concerns about anaerobes because of that, then these would be the drugs you can choose. If they have normal dental hygiene and they get treated with, again, more standard antibiotics. If they have a negative chest radiograph after a witnessed aspiration and they have mild to moderate illness, we recommend not treating. And if they have a negative radiograph but they're very severely ill, at least initially we think about treating and then withdrawing later on. Similarly, if they acquire the aspiration event in the hospital, we divide them up on the basis of chest radiograph, and then we look at them in relation to risk factors for MDR pathogens, and then divide up the therapy on that basis. Antibiotic dosing is also summarized in that review article. I won't run through this, but a key factor to a good outcome is not only choosing the right antibiotic, but using it at the right dose, and certainly the right duration. And we don't know the right duration. This was a study that looked at 100 patients with aspiration pneumonia, randomized to procalcitonin guidance for duration versus clinical decision-making. And what they found is if they used procalcitonin guidance, the duration of therapy was less than if they did not, and the rate of relapse and death was the same in both groups, at least arguing that you could use procalcitonin safely and effectively to determine the duration of therapy for aspiration pneumonia. In terms of prevention, again, what's recommended for everybody, and which I'm going to talk about here, and I believe in strongly, is anybody who's comatose after an emergent intubation should get 24 hours of antibiotic therapy, and I'll show you some of the data for that. And everybody who's going to get general surgery should have no food for at least 8 hours and no clear liquids for at least 2 hours before elective surgery if you have control. There are a variety of other potentially valuable prevention, including swallowing evaluation. I mentioned the ACE inhibitors for blood pressure after stroke. Oral care may be useful. Feeding patients in a semi-recumbent position after stroke. And I think swallowing exercises and oral chlorhexidine, we don't know if they're really going to be useful. Oral care was studied in nursing home patients and really had, in this study, some benefit. It reduced the risk of pneumonia and fatal pneumonia, but other studies like this one didn't show any benefit of an oral care program in preventing aspiration pneumonia. What I want to talk about, though, is the idea of using prophylactic antibiotics, which is something we don't always think about. But in 1999, Dr. Rello made a very interesting observation. He looked at 250 patients who were intubated, and he followed them for pneumonia within the first 48 hours of intubation. There were a small group that developed pneumonia, but when he looked at the univariate risk factors for pneumonia in this urgently intubated population, interestingly, not being on antibiotics at the time of urgent intubation was a risk factor for pneumonia. And that also applied in the multivariate analysis. And so again, the speculation was that the intubation process, urgent intubation, is associated with maybe unwitnessed aspiration and pushing of the secretions deep in the lung. And patients on antibiotics at the time of urgent intubation didn't develop as much pneumonia. That was also happening about the same time that Dr. Torres' group did this prophylactic study. 100 patients with head injury or low Glasgow coma score got cefuroxime 1.5 grams every 12 hours twice. So 24 hours of antibiotic versus placebo. And you can see in the cefuroxime group, the frequency of pneumonia overall and early onset pneumonia was dramatically reduced. So again, presumably, this 24 hours of antibiotic in impaired consciousness patients was useful. More recently, another Spanish study looked at comatose patients, and again, a comparative cohort study for low Glasgow coma score with prophylactic antibiotics, in this time, ceftriaxone, ertapenem, or levofloxacin versus controls, and again, less early onset VAP, less total VAP, and the odds ratio for early onset VAP was quite low in the individuals who were given antibiotics. So I believe very strongly that antibiotics are useful in anybody who's urgently intubated for just a 24-hour period. So I've tried to very quickly go through the topic of aspiration pneumonia. We're pretty much at our time end. I think there's another talk afterwards. So I'm going to stop and I'll move into the back and I'd be happy to answer any questions. Thank you.